Hello everyone, I'm Rachael Lowe from Physiopedia, and today I am talking to Linda Fitzgerald. Hello Linda.
Hello, how are you?
Good, thank you Linda. Thank you so much for chatting with me today. We recently published a new foot and ankle course in Physiopedia Plus, and we've talked before at conferences, but I noticed you in the forum when you introduced yourself that you had an awful lot of experience in treating feet and ankles. So I contacted you and thought we might be able to pick your brains about some of the questions that have come up on this course and delve into your experience and see if we can share some of that knowledge that you have, the clinical experience and knowledge that you have. But before we do anything else, maybe you could introduce yourself to people who haven't met you before.
Okay, my name is Linda Fitzgerald, as you just said. I'm from Ireland, and I went and did my physio training in Trinity College Dublin back in the late 1980s. I qualified, and I worked in a couple of teaching hospitals in Ireland, and then I went to Australia and worked there for about a year. In Darwin and Launceston, to be slightly different. And then when I came back, I worked in a big teaching hospital in Dublin for a year and then set up in private practice and gradually worked my way into private practice, which where my interest was. But how I got interested in the foot and ankle was I had a very difficult patient. I remember I was not that long qualified really. And whatever I did, I got the patient right, delighted with myself. I sent a thank you letter to the consultant, and before I knew it, I had got a letter back from him. Would I like to treat all his private foot and ankle patients in North Leinster? And I said I would be delighted, just setting up in private practice. And before I knew it, I was getting several chronic difficult foot patients a week. And I have just over the years, I'm still working with the same surgeon, so it was a great way to actually get right into it. It was an area I had an interest in. I had done courses on treating feet as well as prescribing orthotics. And so it was just an excellent starter. So I've been interested and working mainly in feet and also women's health, but mainly in feet since then. And that's what I do now, is probably half-time feet.
That's a really interesting way to get into a sort of clinical speciality. I've never heard that sort of story before. I think that's almost a lesson to young physios out there who want to specialise in anything, is to make a good relationship with the local consultants, isn't it?
Absolutely. And the thing is, you get word of mouth from that, particularly as my patients come from quite far and wide. The next thing I know is as I have their next door neighbour coming to me.
Yeah.
Even though they might have travelled 80 or 100 miles to the physio clinic, their next door neighbour turns up next week. So you get the word of mouth recommendations follow on from it as well. So keeping good connections and getting connections with the likely referrals, and the foot and ankle consultants they need the physios. So I find even more than the local GPs. The local GPs will often send to the consultant and then they arrive back 100 metres down the road to me. So I think keeping those good connections and writing discharge letters, letting them know how you're getting on and what you're doing and what you're good at is the important thing as well.
Very good. I think that's very good advice. And in saying that the consultants need a good physio to work with, what kind of conditions do you see? And let's start with that. Yeah.
Okay. Probably I'd see a lot of metatarsalgia, kind of joint synovitis, Morton's neuroma, bunions, lots of plantar fasciitis, and then Achilles tendinopathy, tibial posterior tendinopathy dysfunction, and perineal. That would be the vast. Oh, and the other group would be arthritic changes.
Yeah. Absolutely. Okay.
That would cover 95% of it, I would say.
Yeah. Okay. And with those, without wanting to pick on particular conditions, what kind of are there any common treatment strategies that you use with these individuals that come to you with foot pain, ankle pain?
Okay.
So let's talk about the common strategies first, and then maybe we can talk about if there are any specific ones for specific conditions.
Okay. The very first thing I would say is strengthening. There is one thing, if you have only got one tool in the toolbox, strengthen. You need to strengthen your Achilles for Achilles problem, your tibialis posterior, your intrinsic foot problems for all those metatarsalgias. So if the first thing you do is strengthening, okay. Second thing I would say is reassurance. A lot of the people who have these problems, it's a huge lifestyle change. They can't walk, they can't run, they can't get out and do the things they want. So actually reassurance that, that the exercise strategies do work is actually very important to them. I would use orthotics. Now, obviously not for everybody. So if I need to offload in a particular way, and footwear. Oh, and last, weight management. Very important is weight management. And I think that's an area that physios, we tend to sometimes kind of back off a little bit. But for the number of people who've come into me and said, I know my weight is causing my foot problem, but I can't lose weight because I can't walk. Whereas actually dieting is obviously going to be the big area of that, and just getting them to change their strategy around and not kind of using their foot problem as I can't get this better myself, and to, giving them the tools to actually help with that as well.
Okay, so I'm going to try and, I think that was 5 tips, so I'm going to try and remember those. So let's just talk about each of those individually a little bit. Strengthening, is there anything, there's a lot of talk these days of load management, and where do you start with the strengthening, and how would you progress with the strengthening that you give?
Okay, I'm going to tell you now that I did the tendinopathy course with Physiopedia January a year ago or February a year ago, I think, and it was excellent. And I think it's well worth anyone who's interested in foot problems in doing that course. And the first thing is trying to get pain under control so that they can actually strengthen. And that might be different strategies. That might be where the orthotics come in. If you can't get the pain under control. And then load management. So I would use a lot of TheraBand.
Yep.
Particularly for the tib post and the perineal problems. I would use, for the Achilles, obviously you can use body weight, adding weights onto it. So a graduated program, just increasing the strength along the way, and then onto the kind of the more dynamic and kind of activity based work.
Good. I think that sounds good, and that's what we've covered before, and I think is a good sort of regime for anyone to follow when they're strengthening anything. Next was reassurance. What do you need to reassure people about? What's the common things that they need reassuring about?
Well, a lot of people with chronic foot problems might have had it for years and years, a year to 18 months. And they may have been around the world and not actually got an answer to their issue. And then, I think you need to reassure them that the vast, vast majority of foot problems are correctable with the right treatment. But I also think if you let them know that there is a process, so I would have had people who come in and they've just been given stretches, nothing else. And they say, well, this isn't working. So, and I'll say to them, there's a very good chance we'll get you better. But if we can't, I know the next stage that we have to go to. And that might be referral onto a consultant or further investigations. And I think, and it's one thing I do with all my patients, is I really think it's important that we bring them to a strategy right to the end. That we don't if we don't get them better, we don't give up. We actually show them what is the next step to do. And they will remember that as well. But you don't abandon them just because you didn't get them better. So I think, and having that reassurance that there is a process, I think makes a lot of people very happy, from that point of view.
Yeah, I think that is important. And one of the other things that crosses my mind about reassurance is its relationship to adherence, particularly with foot exercises, which are difficult.
Yes. I don't think they have to be difficult.
What do I mean by that? I mean they're it's lots of little muscles. It's not like strengthening the quads, is it?
No.
Yeah.
But what we do is we actually have videos that we've made out of some of our exercises.
Yeah.
And quite often I'll get particularly say with the TheraBand exercises, I'll get the patient to take out their own smartphone and video themselves, their foot as they do the exercise. And that, I remember at a conference being told that the reasons people don't adhere to their exercises is because they don't believe they'll work. They're not convinced they'll do them correctly, or they think they might make them worse. So if you can deal with all of those, the patients will adhere to their exercises.
Okay, yeah. Okay, good. So we've given them some strengthening exercises. We've reassured them about the process and that they will get better, that we'll see through the whole process with them. So you mentioned when we talked about strengthening and offloading that you might use orthotics. So orthotics is the next thing. And this seems to be an area that's quite diverse in physiotherapy. Some people are experienced and trained in prescribing orthotics, and in some cases I think it's completely new to people. So what are your thoughts on orthotics for physiotherapists working with individuals with foot and ankle pain?
Yeah. Ireland is, I think, quite unusual in that we had no school of podiatry until very recently. So there was a gap there, and basically the musculoskeletal foot physios, we trained into that area. So there's courses regularly on prescribing orthotics in Ireland. So I think it's probably about 20 years I've been prescribing orthotics. Basically, it really depends on obviously what you want to do. And I would have quite a range of off-the-shelf orthotics, or I would actually make molds, cast people, and then I would send them off to a lab, and I would talk with the podiatrist there who actually make the orthotics, and we work together very well with that. It's quite a diverse question as to, who would you prescribe and when, but really the reasons, the kind of criteria would be how long have they had the problem. So if it's something very acute, I'm not going to go much more than maybe a basic metatarsal pad or something like that. Whereas if somebody comes in and they've had the problem for, a year, and often they've multiple problems, they might have a history of shin splints, knee pain, hip pain. They may have had orthotics before, they might have flat feet. They're the ones you might be thinking, okay, this person needs a little bit more control. There's things happening, have a foot not getting better. And they would be the ones I might be considering heading more towards a custom orthotic. So, but it's, it really is very, very individual. And some people come in and they say, I want the best there is, that the custom one or not. And other people will say, I want the cheapest there is, so it's very individual.
Yeah. And how much training or what sort of education does a physiotherapist need to start even just giving custom orthotics? Do you think we need education in this to attend a course or something, or do we have the knowledge already to be able to do this?
No, I think we definitely need postgraduate training with it, yeah. So, I mean, you can do it in a couple of weekend courses, so 4 or 5 days of training. The issue with trying to get started, particularly in private practice, is you're asking people to outlay a lot of money when you're not that experienced. So I think it's very good then you need to be mentored, so that you can maybe follow somebody who's prescribing and, just check that the prescriptions that you're doing are correct. And you can always talk to the podiatrists who are actually making the orthotics, and they're very good. They obviously want the right orthotic to go to the patient. It's in their interest, obviously, as well.
Yeah, so I mean, I think that's quite an important message from you, from someone that's very experienced in prescribing orthotics, particularly in Ireland where there haven't historically been podiatrists. I think it's important that physiotherapists understand that they do need training to be able to prescribe orthotics. So, and that we don't have the knowledge to do that straight away. So it is a sort of postgraduate skill that we will develop, which is good. So, okay, so that's anything else about orthotics? Because that's quite a big question that's been coming up.
Okay, kind of from a general point of view, I think we really should try to avoid rigid orthotics. And I think a lot of the custom orthotics that I would see, and particularly in the older population who need shock absorption, even if they have very kind of flexible flat feet, you want to give them support, but you're not really looking for high control. So I would always go for, less rigidity where at all possible. and they're a lot more comfortable to wear. And the second thing is, I think people think when you prescribe orthotics that they have to put them in every shoe all the time to get benefits. And as I always say to them, it's horses for courses. If it depends on what you're doing. If you're going out for a walk, if you're going shopping and you're going to be in town for 5 hours, if you're going to the gym, if you're playing soccer, wear your orthotic. Okay. If you're going into a restaurant or the cinema or sitting in front of the television, put on your 6-inch heels if you want, because you're only going 10 meters in them, and that's fine. And people are much more likely to when they realize that they don't have to necessarily stop wearing some of their nice footwear, as long as they wear it appropriately, they're much more likely to wear and keep wearing their orthotics. And I think that's very important.
Yeah, absolutely. Okay.
One more thing, if I may.
Go on.
The other thing I see in a lot of the orthotics that people arrive with bags of orthotics is people tend to be very keen on getting rear foot neutral control on it and forget about the forefoot in the insole.
Yeah.
So they'll have rear foot wedges put in, a nice arch, and nothing in the forefoot. And I think it's very important, and this is where kind of the experience and looking at it, that we can work out, why do we have to put, metatarsal bars or metatarsal pads or first ray cutouts, and getting the experience to work out when they are appropriate, because I often think they're underprescribed from that end.
Okay. You make me think about asking you, when you talk about rear foot neutral, about biomechanical assessments and the validity of rear foot neutral. Have you any thoughts on that?
Yeah, I do look at it. I do look at it, people's neutral in supine or prone lying and in standing, more to give me an idea of what's kind of happening. So I don't necessarily try and accurately say, well, we need 5.5 degrees of control here to get certain. It's more, what do I want to achieve with the orthotic, rather than trying to make the orthotic to fit a foot. So it's really, what do you want to achieve? So do you need to disperse the loading of it? And if that's the case, you'd be looking maybe at a 4-foot pad and a good arch control, Or is it somebody who, say, has a tibialis posterior problem, where you need to get good navicular control to control it? So do you need a kind of a high medial archness? So it's not matching to the shape of the foot. It's matching to the function that you want. And I think that's really the important thing, more than numbers.
Yeah, I think that's a good message, definitely. Okay. Now, what kind of footwear are these orthotics going to go in? And you've talked about when, but what? Yeah.
Again, get people to bring in their footwear. What do they normally wear? Ask them, what do they do? For example, you might find they're going out on 3-mile walks every day and they're wearing sandals.
Yeah.
And that's why. And I regularly, it's nearly kind of a September rush of patients who arrive in with problems because they've worn inappropriate footwear and walked far more than they're normally used to on their holidays. And that's actually just, there's quite a lot of people who aren't comfortable, and it's to do with their ankle range of movement in very, very flat shoes. I mean, the shoes that have, completely flat across. And they'll often come in, you'll check their dorsiflexion. And I know there's new research out recently, as we're probably being a little bit too focused on that. But these people, when you come in, they will say to you, you look at it, you'll know they don't have great ankle dorsiflexion. And you'll say to them, I bet you're not comfortable in very, very flat shoes. And they go, oh, I've never been able to wear them, but I did wear those sandals on holidays, So you'll need to take that into account with the footwear and maybe the orthotics as well. Footwear. Obviously, runners are actually good footwear. And it's amazing the number of people who actually think they're not, so a reasonably decent pair of runners are actually very good footwear. Walking shoes, laced shoes are obviously best for orthotics. If somebody wants to wear a fashion shoe, that's fine by me, as long as they're wearing it at the appropriate time. And if you do feel, and again, if it has a little bit of a heel, if you're looking for a nice arch, actually having a bit of a heel will lift the arch. You can get off-the-shelf ones that will actually support. You can get little ones with metatarsal pads as well if you want that for the fashion shoes. But it's really, a lot of it is about education, about wearing the right shoes for the occasion, rather than actually prescribing, you have to wear this sort of shoe.
Yeah. Okay, good. And that makes sense. And that's kind of ties in with what you were saying about when people should wear particular types of shoes. So if they're going to go and sit down, then it doesn't really matter and things like that. Yeah. Okay, so the last common management strategy you mentioned was weight management. How do you approach that with people?
I think most people who arrive in with a foot problem, with a weight problem, know it.
Okay.
I think that, the answer is there. So I think when you're talking to them about, there's too much, for example, there's too much load going on in a certain direction, and you can say, well, some of it is coming from one direction, some of it's coming from another direction, and obviously we have this direction as well, and it's something that we're going to actually need to deal with too. And sometimes that's when that conversation will come up, but I can't walk, so I can't lose weight. So I think you have to, and I'll say, well, exercise might only be 10 or 20% of it. The rest of it is, we're going to need to talk about that, and I might talk about a referral to a dietitian if they indicate that they're having problems. But I think even kind of verbalizing it and making sure that they know that I can't solve all the problems, it has to be a partnership, is the important thing.
Yeah.
Difficult one though.
Yeah, difficult as well, because we spend a lot of time with our patients and individuals, and we as physiotherapists, we aren't trained in offering nutritional advice or anything, are we? And
No.
We're kind of well placed for it, but not trained in it. So how do you sort of overcome that? I know you mentioned that you refer to a dietitian. Is that how you simply overcome that dilemma?
No, I wouldn't necessarily, I don't give kind of specific dietary advice, but I might give little tips, sort of way. Again, you have to make sure you're not crossing outside your scope of practice with it. But some of it, the things that we read in the papers are just smaller plates, smaller portions. I don't think that's, saying very much, cutting out in between meals, making sure you're adequately hydrated. I don't think any of that is crossing any boundaries into it.
Yeah,
but,
absolutely.
If somebody's having a problem with it, they need to get the right advice on it.
Yeah, and maybe we're just a catalyst to bring this part of the condition to the forefront and talk about it.
Yeah, exactly.
Yeah. Okay, so we've talked about those 5 common strategies that you use with probably all of your patients that come in with foot and ankle pain. Are there any other specific treatments that you use for other conditions, or anything, any other sort of knowledge that physios would need to have to treat foot and ankle conditions that might come in? I'm talking about, things like other adjuncts like stretching, taping, electrotherapy. Are there any particular things that you'd use?
Okay, stretching is important, and I think particularly the calf muscle complex and hamstrings, I think, are often forgotten with foot problems, because that can increase some forefoot loading. So I would always check hamstring length. I also think we need to make sure that we don't just do it for the sake of it, because we're asking patients to be partners in the treatment, and then you don't want to give them 27 exercises to do that they just can't get their heads around. So pick the important ones, and that might be your calf stretch and maybe your intrinsic foot muscles, and even just get them started on those, and you can build from that. I think that's important. So stretches, I'll always look at glute strengthening, and one thing that I think is often missed is neural testing. I don't test it with everybody. I will be looking for little clues in the assessment. For example, say someone with plantar fascia problems, classically pain first thing in the morning or after they've been sitting for a while, better if they move a bit, worse if they walk too far. But the ones that actually complain of maybe getting darting, stabbing pain at rest, I hear anybody says it's a stabbing pain or it's darting or rest pain or pain at night, I will always check the back and I will always check the slump. test. And you will be amazed how many of them actually come up positive.
Interesting.
Yeah, and I think that's a very important. And also biasing it, with your foot inversion, your ankle inversion, your ankle eversion, dorsiflexion, plantar flexion, particularly, if the pain is on one side or the other, so you actually bias towards that area. I think that's often missed, and I think that's a very important one. And the clues are often in the patient's description of pain. Mm-hmm. The type of pain and when they get it. If it's that little bit unusual, I'd always look at that.
And when you find that, what do you do about it?
I would use it as a treatment.
Yep.
Now, sometimes you might get somebody who comes in who the other obviously group is if they come in and say, well, I have back pain as well, or even if they have hip pain as well, I'll automatically go and test from that point of view. Now, quite often you'll find somebody who has an acute back problem or has, long history of sciatica. So I would treat it actually using the test that's positive. If they were very, irritable, I'll go obviously a little bit more gently, maybe using slump gliders. If I don't think they're irritable at all, I would go straight into actually getting them to work at home on a slump. And obviously the thing you're looking for is, do their symptoms actually occur when you do it as well? And that's obviously the big thing. If it does, use it as a treatment.
Okay. Taping?
I use virtually no taping.
Ah, interesting.
I can't remember the last time I actually taped a patient.
Okay.
Aside from on the side of a hockey pitch with an acute ankle sprain, but I can't actually remember the last time I taped a patient. Yeah.
Why is that?
Why? Question. Probably because I often would use orthotics or wedging or simple orthotics to get the benefit of it. If I can put in a very simple heel wedge on a very simple insole that costs, €10 or something like that, often the patient will say that's making the difference, so we keep on that. I think taping can be a very temporary thing. I think it has to be put on very well and kept on well. I think I probably can tape quite well if I try, but I think it really. I'm not sure I see the benefit of it in the long term. I think sometimes you can end up taping somebody and bringing them back a week later to see, did that work?
Yes.
Which there are other things can be done.
Yeah. Do you think it's useful for those physiotherapists that don't have any training in orthotic prescription to see if a referral for an orthotic is appropriate?
That could be a reason. Yeah. For example, if you were looking for good arch support or a good kind of navicular control, you could tape it to see. That would be a good reason for using it.
Yeah, good. Yeah. Electrotherapy?
I use very little electrotherapy. Probably the one thing I would use, and it wouldn't be in the early stages of treatment, would be I might use laser for metatarsalgia or joint synovitis. Now, it would be, I don't see a lot of point in using laser and leaving somebody going kind of, if you haven't unloaded them.
Yeah.
But I think it's quite useful for the kind of the end stage, getting that last little bit better. You've unloaded them, they're working on their intrinsics, they've stretched out, they might have a metatarsal pad, and it's still just that little bit sore. I might do a couple of sessions of laser at that stage, and that's virtually it.
Okay. There's some evidence out there for using shockwave in some foot and ankle conditions. Is that right?
There is. I think it's early days yet on the shockwave. I haven't any experience of using it. I know it is available if I did want to refer somebody. I think I've referred 2 people from a Achilles point of view, which is not really enough to give any kind of advice on whether it worked or not.
Yeah.
But I really can't say on that.
Yeah,
I don't
that's fair enough. I think I think with electrotherapy, we're just talking about it being an adjunct onto all those other treatment strategies, aren't we, that you've mentioned? So it's not a primary treatment strategy. It's an adjunct to. It's a kind of added extra at the end, isn't it? Like you mentioned.
Absolutely. And I think it's actually quite important from gaining the partnership with the patient that they don't feel that they have to come to physio to have us do something.
Yeah.
That's more important than their exercises. And actually you have to be a little bit careful with orthotics in that point of view, that the patient don't think that once you put something in their shoe, it's not like a pair of glasses, once you put them on you can see and that's the end of it. That once you put them on in their shoe, their problem will be solved, and if they didn't, physio didn't work.
Yeah.
So, if I have an inkling that the patient is of that mindset, I might actually delay doing orthotics and work on exercises. And it would be the same with using any of the other adjuncts, is that, sometimes you're better off not piling everything on the first. Less is better. Get the patient that it is the exercises. That's the main thing. We might do some other stuff, but that's where you need to go.
Yeah, very, very wise words, I think. Anything else that you use with your patients that you would like to share with people?
Joint mobilizations would be another one that I would use a lot. Yeah. So particularly for the kind of tarsal-metatarsal joint issues, so you get a lot of joint stiffness there, so I would use joint mobilizations. For stiff ankles, I'd use movement with mobilizations, or joint gliding, so I would do that.
Yeah, okay.
I think that's important.
Yeah. Anything else?
I'm a little bit of a fan, whether too much of a fan, of sorting out sagittal plane issues, stiff big toes.
Okay, yeah.
Okay. If somebody doesn't have great dorsiflexion range in their ankle and somebody has a stiff big toe, I think everything in between is going to end up being a problem somewhere along the line, whether they have to pronate, their feet are flattening, or they end up with arthritic changes in the midfoot. And so I would sometimes put in little heel raises. And another little clue that would make me do that would maybe a lot of, if they have anterior ankle pain and a lack of range of movement, sometimes a little heel raise just offloads it for a while. I think the stiff big toe is an issue, and one of the well, obviously you can bend and straighten the toe and see, does it have appropriate movement. If somebody has callus on the inside of their big toe, I think that is a big clue that there's something going on there. They're not moving their toe properly when they're pushing off, so the foot is sliding in the shoe, creating the callus, and that is going to make them load more on their second and third metatarsals, and it's going to probably give them problems in the midfoot as well. So I think that's a clue that there is an issue there. Okay.
With a stiff big toe, is that just mobilizing, or is the joints?
Yeah, I think you can probably gain a little bit with mobilization and stretching. If the toe joint is painful, I think you can. You need to actually make it move better. So one of the ways of moving it better is to put in a metatarsal pad or a metatarsal bar. So it sits a little bit lower, and you'll find that it flexes. Unless it's a completely rigid toe in the first place, it will extend a little bit better. And I think that's our first ray cutout would do the same with that on our nerve.
Interesting.
So I think that's important. There is a group of patients then, certainly towards the end stage of arthritic changes, that if you start pushing and pulling them, you're actually probably likely to flare them up a bit. And sometimes you have to just give up on the range of movement and manage it with footwear. And they're the ones that actually will like the rocker bottom shoes.
Oh, okay. Yeah.
Yeah.
Okay. Anything else? We've talked about a lot. We've talked about, we've done your 5 main management strategies, and plus all the other little adjuncts and pieces of things that you use with your clients. Is there anything that we haven't talked about that you would like to share?
Morning pain, first thing in the morning, particularly for plantar fasciitis. I think that is one of the key things to getting it better. So I would get all my patients with kind of posterior heel pain to roll their foot in the morning before they take their first step. And I generally get them to use kind of a can of polish rather than a golf ball or a tennis ball, which will tend to go in all different directions and only really kind of massages one point. So I would get them to do that, and they should be able to walk pain-free after that. If they can't, they have to put on shoes, even to walk to the bathroom. And if they need to get up to the loo in the middle of the night, they have to put on their shoes. And for women, it's easier. You tell them to put on a shoe with a bit of a heel. Men, that's a bit harder.
Yeah.
But, so if they get that morning pain under control, I think things move on a lot faster. And patients understand that. And they'll work hard at actually getting that under control.
Yeah. That's a good piece of advice. Any other little tips? I don't want to, like...
I have my little...
Oh, have you got it? Good.
I have a little list here.
What have we missed off the list?
Intrinsic muscles.
Yep.
Very important. We mentioned strengthening. I think intrinsic muscles are generally forgotten. And I think it's important that they're trained properly. And the other thing on my little list is activity modification.
Yeah.
So that basically that they're not, with the pain that's aggravated by walking, that they're not trying to do too much. So they'll always ask, how much can I do?
Yeah.
And the very simple to answer is that find out what you can do without flaring it up.
Yeah.
And then you can gradually increase that, because you'll have people going out on, 3-mile hill walks and saying, well, my pain's not getting any better. And say, okay, well, 3 miles might be a little bit much. Let's find out what you can do. And then we'll just build from that as it's getting better.
And that comes back to the reassurance, doesn't it? Because it's only modifying, or it's only backing off for a while they do all their exercises, and then we can ramp it up again and see where they can get to. Yeah.
Yeah.
And then just coming back to the intrinsic muscle exercises, what sort of intrinsic exercises do you recommend?
And the usual one would be the doming exercise. So getting the interossei and the lumbricals working, really making sure that they're not using their toe flexors. I think you can use the tendons on the back of the foot as a guideline. It's something they can see. And so their aim is to be able to do it without all these tendons standing up. And I think that's a really nice biofeedback for them. If you see those tendons standing up, you're not doing it right. So go away and, work on it. I tell them they need to do a lot of them. I have them doing over 100 a day.
Ooh, that's a lot, yeah.
Yeah, but I say to them, divide it out how you like. Whenever you think of it, grab the opportunity to do a few. You don't have to take your shoes off once you're able to do it right, and just work away at it. And they'll come back and say, oh yeah, I'm doing 300 of them. So I think you have to do that volume. I think you have to do a lot of them. I think it's not something doing 10 3 times a day is actually going to get you anywhere. Yeah. And then, if somebody has real difficulty with them, I'll put a little pad into the shoe to give them the support while they're waiting for it to get stronger.
Good, yeah. Okay, that is lots of really good advice for people, I think. Lots of really good tips for people to look out for and consider when they're working with individuals with foot and ankle pain. Is there any sort of other advice that you'd like to give or like to share with physiotherapists around the world that we haven't talked about, or that's sort of key for people to think about?
I think knowing your anatomy is important.
Yeah.
I think that, we really need, the foot is a complicated, not that big, but quite complex inside. So I think knowing your anatomy is very important. And I think progression is important as well, particularly of strengthening exercises. I think that's something sometimes we could do better, So we might give an exercise with a blue stretchy band, and then just check you are still doing the blue stretchy band exercise the next day. I think you need to test, you need to progress, and whether it's in the number of repetitions, the number of sets, or a stronger band. So I think progression is very important, and I think sometimes we're not great at that. I think it's something we could improve on. Getting the patient doing it correctly and checking that is also very important, particularly with foot exercises. It's a long way down there.
Yeah.
So I think it's important that you check once you've given an exercise, don't assume that they're doing it correctly. I have fallen into that trap myself and thought somebody's doing something different. Or sometimes they modify them themselves. I thought it would be better if I did it this way. It's really important to go, let's go over the exercises we did the last day. How are you getting on with them? Checking them. Okay, we can progress that. No, we need to alter that. I think that's important. And the other thing I think we need to do is to write down the programs.
Yeah.
Yeah.
So that the person's got something to refer to.
Something to refer to.
And I think the way you mentioned about videoing the exercises as well, even just doing it on the patient's phone, so they've got their own, done it themselves. And I think this is really nice because we've come right back round to exercise again, which is just highlighting how important this is as the sort of primary management strategy in foot and ankle conditions, and as it is with most things that we do, and what we're very good at. So that's probably a really good place to end. Is there anything that I haven't asked about or that we haven't discussed that we really shouldn't finish without?
Okay, well, I think that treating foot and ankle problems is really good fun, and it is really satisfying as a physiotherapist, because people who have a problem that you can usually solve might be completely debilitating for them. And they're usually very grateful when you do sort the problem. And even just little milestones like they can now walk a mile, they're usually delighted with that. So it's a really satisfying area of physiotherapy to work in. So I would actually recommend that people do work it. There are lots of groups around as well, so even if you find you're on your own, there's a lot of online groups, foot and ankle groups as well. So look them up in your area. I think that's good because, and if there isn't one there, start it.
Yes, yeah, absolutely. And where can people find out more about you, Linda? Is there anywhere online, or are you on Twitter? Is there any way that people can contact you?
I'm an avid Twitter user. So I have where you have a work Twitter handle, which is at ashbournephysio, ASH1 physio.
Yeah.
Then I have a personal one, which is it's Linda Fitzgerald, my name, but it's at Linda J Deacon, DEACON, and it's Linda with an I. So one I use for personal and work, and the other is purely my work one. Either is fine. Our work website is www.ashbournephysio.ie. And if anybody wants to email me with any questions, they'll get me on, wait for this, oisyplinda@gmail.com.
Okay.
Now, that's physio backwards.
Oh, is it? It's very good of you to share your contact details with people so that they can contact you to ask questions. We will share these when we put this video out. We'll put all the links as well, so people will be able to click instead of remember what you just said. So, Linda, thank you very much for talking to us today. It's been completely insightful, and I think we've answered a lot of the questions that came up in the initial instance of this course. So thank you so much for clearing those things up. It's been a pleasure to talk to you today.
Thank you.